My name is Carmen Morano, and I have the incredible blessing of being named the director of the Hartford Silberman Center of Excellence in Aging and Diversity. We're very proud of this distinguished award. We're one of only 5 programs, 5 schools of social work in the country that have been recognized by the Hartford Foundation as a center of excellence. This was originally intended to be a quasi-soft kickoff for our center, as well as to bring Dr. Mahoney here to speak about a topic that, as I spoke to individuals, everyone's saying, we need to be talking about this. This is happening in New York at an unbelievably rapid pace. So if I can beg your indulgence, let me introduce my colleagues from the center and just take a moment or two of your time to tell you a little bit about the Center of Excellence, and then I will turn things over to Dr. Mahoney. But sitting in the rear is Dr. Daniel Gardner, who's being shy. He's exhausted. He's actually been working in the community pretty much all morning with part of our trying to coordinate some volunteer assistance with what's happened here in East Harlem. Dr. Gardner is the director of our research core. In establishing our proposal, we approached it from a concept of having 3 intersecting cores, and Dr. Gardner leads our research core, and I'll speak briefly about that in a second. Dr. Nancy Junta, who is sitting up front and will help kind of co-facilitate this afternoon's event. Dr. Nancy Junta is the director of our Practice to Policy core, or if some are, like myself, are dyslexic, I see it as the Policy to Practice core. But those of us who work in real life know that they are reciprocal, and you can't have one without the other. Unfortunately, Dr. Carolyn Gallman, who heads our Education and Lifelong Training core, unfortunately for us, she's not with us here, but fortunately for Dr. Gallman, she's been spending most of this academic year, starting in August, in Paris, working with her family as well as her husband, who's doing some kind of research in Paris. So while we feel badly that she's not here, every week when we have our center directors meeting and we beam her in from Paris, I think my colleagues would admit she really has the best end of this deal going forward. The mission, overall mission of our center, and it's really been driven by the funding priorities of the Hartford Foundation and the Gerontological Society of America, is really not to be one of those academic centers of excellence where we sit in our little ivory tower and we think of fancy ideas to then come to you, the community, saying, oh, we've got a great idea, we'd like to do some research at your agency. In fact, it's the very opposite. The whole, if you will, mission of the Center of Excellence is to be a link between our academic centers and the community, and to be driven by the needs and the issues, the topics that you, our community partners, are living and breathing day in and day out. So to accomplish some of our goals, what we've done is we not only established a national advisory group of experts from around the country in gerontological education, research, and policy. We've created a community council. And we actually held our first community council meeting, about a month or so ago. Is that about right, James? Yeah, about a month or so. And probably a number of you, just by getting the invitation, probably were on our invitation list. Those who were not able to attend our first meeting, please don't fear. There will be plenty of opportunity, because we really do see the vital importance of having this reciprocal relationship where you are really informing us and not us informing you. So as you go back to your agencies and you think about training needs that your workforce might have, we hope that you think of the center and how we can help you to accomplish your goal of training your workforce. As you think about research in your settings, I'm really happy to announce that Dr. Gardner will be releasing an RFP very shortly, where we have a small bucket of money that we'll be offering to community agencies, our partners, to engage in some type of what we'll call small pilot projects that we will not only contribute some dollars, but also the expertise of our faculty. And really, again, from, as my colleague Dr. Junta and Dr. Gardner is teaching me, from more of a participatory approach that really emerges downstairs in the street rather than upstairs in my office or any one of our offices. So I'd love to go on and wax poetically about the center. But as you can tell, my passion for gerontological social work practice and education research goes long, is long standing. To be in this environment under the leadership of Dean Mondros and to work with colleagues like Dan Gardner, Nancy Junta, Carol Gellman, has just completely re-energized myself. And as I was saying to the youngest member of our team, Dr. Junta, I keep learning things from Nancy like day in and day out. And one of the important lessons I'm learning from Nancy is how to be quiet. And those of you who know me know that doesn't come easy. But when we were talking about this particular presentation, and I will explain to you, Kevin, Dr. Mahoney, has already presented once to the faculty for about 90 minutes, and then was invited to have lunch with our doctoral students, and that 1 hour luncheon turned into about 2.5 hours of question and answering, so much so that we got relocated out of our meeting room into a cloakroom with a copy machine. But the students were so engaged in the conversation. So this is his third discussion. But we thought we'd approach this a bit differently. So I'm going to ask Nancy to come up, and she's going to kind of start this, and then I'll come back and we'll introduce Dr. Mahoney more formally. But Nancy, you want to step in?
Welcome, everyone. As you know, I'm Nancy Junta, and the Director of the Practice and Policy Core, which also means I'm the token community organizer in the center. And we are taking more of a participatory approach to this session here today. So rather than listen to us speak for very long, what we thought we would do is ask you to introduce yourself so we get a sense of who's in the room, so we can draw on some of your expertise here, and so that Kevin and Dr. Mahoney can also kind of individualize his talk to meet your needs here and answer your questions and draw on your own expertise. So if I could invite you to introduce yourself by telling us your name and either the agency you work for or the organization you represent, and if you have a burning issue that you would like to bring to the room here around participant-directed long-term supports and services, that would be wonderful. If you'd like to share some of the experience you bring with you and your expertise around participant-directed services, we'd love to hear that. So if you could just take about a minute to introduce yourself and share anything you'd like about your background in participant-directed services, that would be wonderful. If I start with,
That's okay. My name is Alma Collazo. I'm a social work program coordinator at a senior housing here in East Harlem. I'm also part of Mount Sinai Hospital. And many of my clients are in long-term service programs. And also I'm on the older adult subcommittee, which is part of the East Harlem Health Committee.
I'm Anna Fay, and I work for the Independence Care System, which is a Medicaid-managed long-term care plan, and we specifically target as our membership people with physical disabilities and chronic conditions. And recently, with mandatory enrollment, we have many seniors. Our membership has really changed considerably over the past year and a half, where most of our members were between the ages of, say, 35 and 50. Most 60% now are over 65. So, and we do have a consumer-directed personal assistance program, which has broadened in its, well, the goals are the same, but it's broadened in its relevance to our plan.
I'm Alan Kahn. I work with him at ICS, and I'm a social worker, and I also help train social workers at ICS, field training.
Hi, good afternoon. My name is Raina Taylor. I'm a social work manager at Visit Nurse Services of New York, manage long-term care program. We do have a consumer-directed care program that's very much in par with this particular model, and we work with an interdisciplinary team to provide services over the continuum of care.
My name is Bob Franco. I work for SPOP. SPOP is short for Service Program for Older People. We have three major components to the agency. We have an OMH licensed clinic, bereavement services, and a PROS program for older adults. We are the only PROS program in New York City for older people. And we just converted from a continuing day treatment program to PROS back in October.
My name is Jody Smith. I am a first-year student here at Hunter for social work, and I'm specializing in geriatrics, and I'm happy to be here to learn more. I intern currently at the JCC in Manhattan, and had a bunch of different volunteer experiences with older adults. And so.
Agnes?
My name is Agnes Kolarowitz. I'm a doctoral student, first-year doctoral student here at Hunter. I'm also a geriatric social worker, and I work I'm a Silberman Fellow working on the care coordination project here at Silberman.
Sure. Go for it.
I realize I am not the token community organizer. We also have another community organizer in our center.
Yeah.
Okay, I'm Rebecca Gluszewski. I'm the program manager for the Silberman Center of Excellence in Aging and Care Safety. And
Hi, my name is Carolina Villanueva. I work upstairs at the Brookdale Center for Healthy Aging. I'm a research associate there, and we're currently doing some research trying to have the community be involved. So that's why I'm here today. I'm interested.
My name is Ashley Faustin. I also work at the Brookdale Center for Healthy Aging. I work in the Learning and Development and the Research Core. I'm very involved in the project that Carolina just described, so that's why I'm here.
So I'm Dan Gardner. Dr. Morano talked on and on about all of us, but I'm an associate professor here on faculty. I'm also interested in older adults, but my areas of interest in particular are around chronic illness and care, palliative care. So I'm also working with the Brookdale Center for Healthy Aging around a community-based program, community-based needs assessment and eventual program development around palliative care in East Harlem and Central Harlem.
My name is Matthew Caron. I'm from the CUNY School of Public Health, previously the Brookdale Center for Healthy Aging. And I was working for 7 years on a project with the New York City Department of Health and Mental Hygiene, assisting adult care facilities and their residents in a variety of areas as a vulnerable population.
I'm Igor Malinowski. I'm a project director on the mental health needs assessment survey that Silberman is doing with New York City Department of Health and Mental Hygiene. My own background is in research in the recovery model and in severe persistent mental illness. So I also like to expand my horizons every once in a while. That's not here.
And Robert.
Just wait. So I'm Dr. Robin Fenley. I'm Deputy Assistant Commissioner at the Department for the Aging. I've been working in aging forever, it feels. Formerly, I was director for the Alzheimer's and Caregiver Resource Center. And the issue of participant and consumer-directed care is really, really important. I mean, we hear calls all the time from family members, how can I be paid to take care of my person? I'm also overseeing a CMS project for community-based transition care, which is really trying to get the, well, it's really about reducing readmissions to hospitals, but about empowering the older adult once they are discharged so they can take care of their own care needs.
And I do believe that's a rather recent title.
Yeah.
You just kind of sped through that. But
Yeah, how about that, right?
Yeah.
Yes, that's right, it's a recent promotion. Yeah, thanks, Mom. Yeah. But actually, our commissioner, Donna Corrado, just also recently appointed, she is very much interested in disabilities. I know she did her dissertation on disabilities in the older community, so she and I have had some conversations. So, in fact, she would be here, but she's not, so I'm here.
So, real quickly, I just want to introduce Dr. Kevin Mahoney, and as you can see from this.
Just to reflect, we have an excellent representation of policymakers, program directors, direct service workers, students, and researchers. So I think this will be great.
I think not only will it be great, but I think it also speaks to the work that Rebecca's been doing, who I did not introduce as one of the directors, but truth be told, she's really each of our directors. She keeps us on point, on target, and none of you would be here if it wasn't for Rebecca and her capacity to really bring us together. And Nancy's right when she said she's not the only community organizer, because if it wasn't for Rebecca's organization, I'm not sure where we would be as a center. Anyway, Dr. Kevin Mahoney, I'll spare him the embarrassment I did this morning with his introduction. But it's just been a real treat for me when this grant came out to implement this person-centered care, participant-directed care project, and I was invited to be, for New York to be one of the sites. It really gave me a chance to start working more closely with Kevin than in all the years that I've known him. He received his PhD from the University of Wisconsin, and has really been at this a lot longer. And I think one of the things that I took away from both of our discussions this morning is that the work that he's achieved has just been phenomenal, and I'll leave it to him to tell you about it. But when you learn who he is as an individual and what he brought to this and his journey, not only from the side of designing and developing, but then utilizing person-centered care, it just really speaks to why this is really where I'm excited to see the city of New York, the state of New York is really taking giant leaps and advancing the whole agenda. So with no further ado, I'm going to turn the floor over to Kevin. Thank you, Kevin.
Okay, thank you, Carmen. It's certainly a privilege to be here with all of you and to hear of your disparate journeys and tasks and needs. So let's see, I am Kevin Mahoney. I'm in my other life a professor at the Graduate School of Social Work at Boston College and director of this National Resource Center of Participant-Directed Services. Why I'm really especially grateful to be here for today's presentation is really so that, because it's part of the kickoff of the Center for Excellence here at Hunter, at the Silberman School, really to keep it on a focus at the end of how can this be useful to you, what kinds of training needs, what kind of of opportunities this can lead to. But my presentation is entitled Participant Direction for Long-Term Services and Supports for People with Disabilities, Past, Present, and Future. The PowerPoints, I'm sure, can be available to all of you, which is why I'm going to feel free to use them as a backdrop, so we save most of the time for talking. I have been working in this area, amazingly enough, 19 years. Really, my participation in this grew out of the Clinton Health Plan, which amazingly had a modest long-term care benefit. But people from the disability community had championed really the thought of this consumer-directed alternative. And along the lines of saying, look, when I have needs with bathing, dressing, transferring, in most states I have to go through an agency. For many that's perfect, that's great. But for some the issue is I don't have a say-so in who helps me. I may have multiple people, different days. I don't have much say on when they come. For some people that meant if they may need to go to bed at 7:30 at night or a time that just didn't fit with their needs. And agencies in many places have serious restrictions. Can't take you in my car. I have a New Jersey experience with a woman with MS. The agency could do her laundry, not her children's laundry. I mean, the agency came in 4-hour loans. It was that types of issues. So it really came from people in the disability community. If I had more control over my life, I think it would be better. My life would be better. I think I could do it for the same amount of money, maybe even less. That was the impetus for this. Believe it or not, the Cash and Counseling, which is the name of the demonstration I had the chance to lead, many of the ideas came from the Netherlands, some from Germany, looking at other countries. Some of them we really honed and developed as the demonstration went on. So today I'm going to talk just a little bit about the controlled experiment, where we are today, and what some of the future challenges are. The Cash and Counseling demonstration, it was that rare moment in time, of course, a foundation, and on the federal government side, the Assistant Secretary for Planning and Evaluation partnered right from the beginning, and their feeling was, here's a topic it's one of the rare topics that justifies a large controlled experiment. It's an area that needed more light and less heat. It was an area that people said cash and counseling. Some people said fraud and abuse, others said neglect. I mean, others thought it was the best thing in the world. But it was a feeling that it was a controlled experiment would make a difference. So what we really, I'll say, the major attributes of this cash and counseling demonstration were, one, we were going to test this idea on a large scale. 3 states, originally a 4th, which was New York. And I can tell you later on if you want to know what happened in New York and why New York didn't go forward. But 3 states, 6,700 people. The second thing about it was we wanted to use the purest form we could of participant direction. That's what this budget authority that you've seen already. People were given control of a budget roughly equal to what an agency would have spent on their behalf, and they could do anything that they want. They had to develop a spending plan for how to use it. It wasn't an SSI check, but they could hire even close family. They could buy assistive devices, goods and services, renovate their homes. The litmus test was it had to tie back to meeting their needs to stay independent in the community. So large scale, a strong form of participant direction, more than the employer authority, which is more prevalent mode here in the CDPA component. The third thing was rigorous evaluation. This was random assignment, pure and simple, but one of the stronger forms. I can go into the whole research design with anyone who wants to. The last thing, it was a robust model. Every state tested it with the elderly, everyone with adults with physical disabilities. Florida added 1,000 children with developmental disabilities and 900 adults with developmental disabilities. SAMHSA later had us reanalyze all the data, and we found by state 18 to 24% of all the people in the demonstration had behavioral needs. So we reanalyzed it for them as well. So it's a robust model. As I say, 3 states, it was an alternative to a Medicaid personal care program in Arkansas. New Jersey, which is an entitlement, it was an alternative to 1915C waivers, 3 of them in Florida, which means nursing home level of care. Every state is different, so different, but this is the core similarity. People entered the system like they always did, got an assessment just like they always did. Step 2, a dollar value was assigned to the care plan they would have received in their state. Different models for doing that. I say talk for hours. Florida for a while tried it based on last 6 months of expenditures for that person. That may work if you have a stable care plan. Most of the states costed out the care plan. Now many states are to the point they have enough data to do algorithms to say that this person, based on their needs, their level of support fits into this utilization group, and you get this kind of a budget. People were then given enough information to decide if this was for them, often with their family. This is a real art. How do you give people enough information to decide this works for them? I'll come back to this, but it was at this point in the original controlled experiment, it was people that were interested in this were then randomized at this point in the control. That's not true today, but that's how this happened. Step 4, the person with their support broker, counselor, coach developed their spending plan. And step 5, people who needed or wanted a representative, that they could manage but couldn't manage totally on their own, were allowed to do so. We had a lot of pressure, actually from the New York Alzheimer's Association, who said, in the past there just been directions just for those who could do it all on their own. And people with Alzheimer's, they were arguing, certainly have strong preferences, able to show them, and it could certainly benefit from an individualized plan. So we borrowed this idea of a representative. The Robert Wood Johnson Foundation was generous enough that we had focus groups in each of the states, followed by a survey of a representative sample of the home care recipients in each state, followed by more focus groups. And it helped us to know things you wouldn't necessarily have guessed. 99% of the people didn't want the cash, even though that was always an option. But for those who want to hire a personal care worker, you have taxation issues, immigration issues, labor law issues, bookkeeping issues. So they wanted a service to do the bookkeeping, check writing, tax paying. Come now to be called financial management service agencies. The other thing they wanted is they did not want a care manager in the traditional professional knows best, but they wanted that person. How do I think creatively about my needs, and what are new ways that they could be met? How do I find the resources? How do I find workers if I don't have them already? How do I develop a backup plan if the worker didn't come? How do I find or get the training that the worker may need? How do I fire my mother once I hired her? So this is the sort of the essence of the model. So the 3 original states, Arkansas, Florida, and New Jersey, I'll get in later because at the end of the controlled experiment, we actually received funding from the Assistant Secretary's Office, Robert Wood Johnson, and the Administration on Aging to do a 12-state replication in Medicaid. So the green states were the states we worked with in efficiency testing, the replication. just a feel for the results, because this is part of this has been part of what's important to get people to pay attention and be surprised or rethink deeply held views. So here's the key to all of these, so you can look at them in your own time. T is the treatment group. That means the people who got to manage the cash allowance. C is the control group that stayed with agencies. We separately analyzed each state, Arkansas, Florida, New Jersey. We separately looked at non-elderly with physical disabilities, the elderly, and children. Statistical significance, every time you see a star, that's significant at 0.05. Every time you see 2 stars, it's significant at the 0.01 level. That's pretty strong. This is one of the most important results for the future, and it's a simple question. Yes, the treatment and the control group, did you get any personal care in the last 2 years? Did you get any? So look at Arkansas. 95% who managed the budget themselves said yes. 95% of the elderly who managed the budget themselves said yes. But in the control group that stayed with agencies, only about 2/3 of the adults with physical disabilities said yes. And only about 80% of the elderly said yes. That's dramatic. It's certainly part of the reason some states had for doing this was to add to the workforce at a time that it was getting harder and harder to find workers. People could bring in people often who cared about them and were willing to be there because of that person. Some of it was issues in rural areas, etc. But this is a key quality measure for agencies to pay attention to. It also scared us a little about costs, because how do you get cheaper than zero? On the other hand, what state wants to balance their budget based on the fact that predictably people do not get prescribed care? We had 4 quality types of outcomes. One was, are people satisfied with very specific aspects of their care? The worker comes on time, the worker respects them. These results, the evaluators from Mathematica said in their whole lifetime they had never seen results of that magnitude. And this is comparing, very large groups across states. Had fewer unmet needs. This one you can guess, because if I can tailor the money to my own individual life, why wouldn't it? I mean, I could get transportation, I could get what I need rather than a more cookie-cutter approach. We had no hypothesis on health outcomes, but we had 11 health outcomes. This is just an example. But they were things like decubitus ulcers, contractures, falls, burns. Out of the 11 measures across 7 populations, in no case did those receiving care from the agencies do better on any measure with any population in a statistically significant basis. On the other hand, in 1/3 of all the measures, people who managed themselves did 20 to 50% better. So remember this when we come back and talk about some training issues, some neglect issues, some planning issues. Averages belie the fact that it affects people differently, but this is a starting point. Overall life satisfaction is sort of a global measure that often doesn't show much. This one is important, but it becomes more important when you realize the average benefit in a state like Arkansas was $340 a month. I mean, and if I could change your whole feeling about your life, that's worth thinking about. For family, this was another part. The family had less financial, physical, emotional strain. We looked at the experience of the workers the participants hired versus the experience of the agencies. You'll notice that in at least 2 of the states, when the participant controlled the wage, they paid more than the agencies did. But I mean, there's numbers of things you can learn about the workers' experience. As to costs, remember, there were 2 ways to do this. For us, we were comparing the total treatment to the total control. So in every state, home care costs went up. mostly because people were getting care. But in each state, the nursing home and hospitalization costs went down. So these states had a goal of, not saving money, but serving more people and serving them better. So in Arkansas, you basically had a break even. We had a year's worth of Medicare and Medicaid data on every individual. Because it took 2 years to recruit the people, in most cases, half the cases, we had 2 years of Medicare and Medicaid data. In Arkansas, when we went back and got a third year, we found an 18% reduction in nursing facility costs. So that's the controlled experiment, and it was a lot of what, with help from the Robert Wood Johnson Foundation, you really had a rather brilliant effort at communicating these results. This may bore you, but like we never did a final report. We went right to journal articles. We did very nice glossy brochures of the highlights of the results. We also had a qualitative part of the study that followed, an ethnographic study that followed 25 people in each of the states and their stories. So this was for legislators across the country. We did a manual, a handbook for the program administrators, because the process evaluation for this guided us on how do you do this when you do the replication. So where is it today? So as I already told you, we went from the controlled experiment, takes a long time, but that was over by 2003. The next stage, 2004 to 2008, was the replication in 12 state Medicaid programs. Now, where are we today? One of the things our center 5 years ago, April 9th, morphed from being the Cash and Counseling National Program Office into being a national resource center on participant-directed services. One of the, with funding from Atlantic Philanthropies, Robert Wood Johnson Foundation. One of the things we do is do every 3 years update. We call it our national inventory on the growth of participant-directed programs. But I'll fly through this. This sort of charts the growth. At this point, you have over 800,000 people in the country using some form of participant direction, either employer authority or budget authority. Every state in the country has at least one program where people can hire their own workers. And 44 states now have at least one program where people can manage their own budget. I think it's like, these are the types of groups, this is the types of funding. There's over 286 programs. The data from our national inventory informs, we work closely with AARP, and this becomes part of the state scorecard, long-term services and supports scorecard, et cetera. But this, for us, is the outcome measure, since we're somewhat single-minded on this option being available in a growing way. So, the future. Here I'll just touch on things, but this is one place to start. What's the future? AARP, this is a survey they did of their members, random sample, asking them if and when you need help in the future, bathing, dressing, do you want to manage it yourself or go through an agency? 75% say, I'd like to have a major say in doing it myself. The other big argument for this, and I'd love to talk more about it, but it's like one of the things that's very clear, when we did the focus groups in the beginning, non-Caucasians were 2.5 times more likely to want this option. People of different ethnic and racial groups, very different patterns on how they spent the money. So the growing diversity of the United States is another reason for considering this. I want to talk about managed care, go a little deeper, integrated care, training needs, opportunities for new populations at sort of breakneck speed. But, here's the wake-up call we had, and you've got it even louder here in your state, and everyone sees this. But what we realized is like 26 states within a 2-year period either had or had publicly announced they're moving of home and community-based services to managed care. So we were lucky enough to have the Medicare-Medicaid Integration Office that handles the duals demonstration. Mathematica handles their technical assistance. We have a contract with Mathematica, and one of the things they asked us to do is, of the first 16 states that moved to managed long-term care, 12 of them included participant direction. So they wanted us to analyze the RFPs, the contracts, the policies, and the procedures of those 12 states. Then we were lucky enough to get a separate contract from the Assistant Secretary for Planning and Evaluation to do a deep dive and do case studies on 5 of those states, to go and actually visit them and see how participant direction was managed and evolved. So I'm gonna, this you can look at later, and if we spend a lot of time on this, we won't get to all the discussion I'd love to. And I'll come back to this managed care. These were the 5 states that we ended up doing the site visits, et cetera. And then we had a separate contract from Mathematica to look at the first 8 states that had signed their MOUs under the duals project, and to examine closely the three-way, the tripartite contracts between the state, the managed care organization, and CMS. Those are the 8 states, New York being one of them. And New York being one of them was the best, from our perspective. And I'll tell you some of the, these are the types of things. A lack of participant direction standards and requirements. I just give you an example of the 12, in that study of the 12, 5 of them offered the budget option, 7 just the employer option. Florida, in the process of going to managed care, dropped the budget authority. Hawaii's use of the budget authority merely lets the person set the wage. Texas, what people can spend the goods and services on, is a very limited list. I'm just giving you examples. The implementation is delegated to health plans that may or may not have experience in long-term services and supports. And even the ones that do, this thing about, we might talk to care managers and they'd say, well, how do you tell a person about this option? And we'd say, well, talk to Mary, she's the only one that does it. Or you should, the stories that come out of the care, of the actual case study are revealing. Tennessee, that's one of the states that pays the most attention to participant direction, we found the take-up rate varied from 0 to 25% based on the care manager, which starts to get us into training types of issues. The issues about quality measures I'll come back to, but I'll give you a highlight. In the duals project, 6 of them, their only measure of quality in participant direction was, are the care managers trained? We asked them, how do you monitor the financial management service agencies? They said, if we get complaints. New York is the only state that really, Tennessee among the original 12, New York and Washington are states that go better on that one. So we ended up with recommendations about, we would love to recommend that this be a required option. In CMS's Medicaid letter to the states doing the duals, they said if your state's already doing it, you have to do it. If you aren't already doing it, we would like you to do it, but you have to provide the supports, the financial management services, et cetera. But this area of best practices, I was regaling them this morning. It's easier for me to do a list of worst practices, and I'd be glad to do it because the very thought of states repeating those would be horrendous. As far as training, what good is it to have a quality measure if the care managers are trained if it doesn't say what it is or how do you do the training? So we will hopefully be working with Mathematica on training guidelines, and that's the type of thing that I think a place like Hunter could be very useful to all of you. This last one is my favorite, about developing quality measures, outcome-based, etc. What? Data requirements. If you don't have data, you will never know. And states are falling into this as they go to managed care where they aren't keeping the right data. And my best example, back to our national inventory, we try and keep track of each state's growth of participant direction. So when we contacted Kansas, they said, well, we just don't, now that we've gone to KingCare, we can't tell you how many people are participant directed. We kept after them and they said, okay, if you pay us $400, it will take us 16 hours and we will provide you with debt. So this is my canceled check. My staff are smart enough to wipe out my bank account numbers. But this is my canceled check to the state of Kansas. If CMS does not move towards requiring this in some standard way, what's the future allow as far as being able to track and do quality measures? Minnesota's even worse. They tell us, first they told us they couldn't get it, now they're telling us if we pay them $32 an hour, they don't know how many hours it will take, and they can't promise us they can get the result. But this data one is one we're not going to lose. For the reasons for doing participant direction, we come back to people. Integrated care is one I'd love to talk more of, but as you try and integrate acute behavioral and long-term services and supports, how do you do this? Does anyone have, we gave a grant to Commonwealth Care Alliance, a nonprofit in Massachusetts. Now their position was, how in the world do you reconcile managed care, and participant direction? Who's got the power? How can I be in charge of everything if they're doing what they want to do? So we really, with them, I went out on site visit, went to care coordinator meetings, visited people in their homes, but it was trying to develop shareable protocols on how do you do this. And we've had sort of a think tank of how does everyone's role change under integrated care, behavioral health? Does the representative have more roles at episode, when the person's mental health trajectory is different, other workers use different. Training needs is the place that brings me here, and where Hunter is working with the VNS. But again, I'll just give you the quickest of stories. Arkansas and New Jersey, this is harkening back to the original demonstration, set up a whole alternative delivery system for the support broker, the counseling role. Doesn't sound necessarily very efficient. But Florida decided to use existing care managers. So in Florida, but for children, after 3 months nobody had signed up. So we started doing focus groups with care managers, with their supervisors, and learned a lot of the issues about how much of a switch this was, of different types of training that people needed in order to be comfortable with this. Some people, can the participant really do this? I told the story this morning about the training Minnesota did on web-based for the whole. And at the end, one of the care managers in the northern part of the state had left her phone on and was heard to say, and they think we're really going to do this? But the whole needs, and this is, the grant we have from the New York Community Trust is working with 9 schools of social work around the whole country, Hunter being the lead here, to look at what are the core competencies, what are modules for person-centered planning, we call it personal. How do you inculcate that into the learning for bachelor's level as well as master's level? How do you develop it and infuse it into the courses? This is a grant I care deeply about. New populations, I'll just touch on the first. We were lucky enough, as we became a National Resource Center, to start working with the Veterans Health Administration. And they were dealing with the issue of people coming back from Iraq and Afghanistan, many injuries, not feeling the current service delivery system met their needs. And we have worked closely with them to develop this veterans-directed HCBS program. At the point we were in, it goes Veterans Medical Center by Veterans Medical Center, and each medical center contracts, because the VA knew they could not expand that quickly, they contract with the Aging and Disability Network to deliver and provide this service. At the point that they were in 27 states, 43 VA-MCs, we did the first level of evaluation, which has led to it becoming a permanent option in the VA. But it also opened the door for them to realize that 81 cents on their long-term care dollar goes to nursing homes. So we have been working with the VA on a rebalancing effort and a whole system for allocating dollars within their home care system. And the new frontier for me is behavioral health. There have been small demonstrations, meaning a couple of hundred people, again, controlled experiments. Delaware County, Pennsylvania, Dallas, Texas, Florida, some 4 in the United Kingdom, of testing the self-direction of behavioral health and how does it fit so beautifully, I would think, with the recovery approach, with the greater use of peers. So we've worked with Robert Wood Johnson for 2 years doing an environmental scan, including focus groups with participants, peer providers who are especially valuable and important and critical, as well as traditional providers. So January 17th, with SAMHSA funds, the National Association of State Mental Health Program Directors, that's a mouthful, made awards to 5 states to be the ones to begin testing this, and the states are New York, Pennsylvania, Michigan, Texas, and Utah. So we're working with the Robert Wood Johnson Foundation on what we're hoping will be a large-scale test in behavioral health. Again, you don't go anywhere in the story without it being, what does it mean in the lives of the people that, is it a matter for some people of control and a point I really need and don't have? Is it a point of flexibility? Is it a point of I want to be better woven into the community? I mean, I'm a story person. I guess it fits for St. Patrick's Day. It's the Irish tradition. but I mean, I'll sort of end with this. Like it's a Minnesota story of this fellow who was really failing to thrive. I mean, he was just withering away, and his care manager did not believe that he was participant-directed approach, but somehow they agreed to try it, and at the point he was able to hire someone that he really cared for and got the kind of food he wanted. But more important, his wife was in a nursing home 25 miles away, next door to a grocery store. So the person he hired could take the guy, fellow in the car, and he could visit his wife, and all of a sudden the world turned around, and that care manager became the greatest salesperson for this program we could ever see. So that gives us, hopefully, time, but especially to talk about, well, what do you think about this? How does it fit in your agencies? And I know people from Hunter, either today or as time goes on, want to talk, how can they be helpful in meeting your research or training needs?
I actually have a question. So it sounds as though who gets hired, sometimes it sounds like it's a care manager, but when in New York, when we have the this cash and counseling program out of the HRA program, it's family members that are hired, and they cannot be the first degree family.
Yep.
Do you have? I mean, so is it family and care managers in some places, and do you have in these other states? Is there that similar restriction?
So let me tease that apart if you'll let me. So what I'm really talking about is participants hiring their own workers. Not talking about the care managers. Amazingly enough, people often think Medicaid forbids the hiring of family members. It never did. The only family members that you could not hire were legally responsible. So a husband, or spouses, parents of a child, and a guardian. But starting with cash and counseling, because Minnesota was the first state to work it through the 1915s. I mean, we can work it through in 1115 like New York is. Sorry for the jargon. But you can now, even under a 1915C home and community-based waiver, arrange for even legally responsible people. So New York had a more restrictive law than anywhere else in the country. I don't know if it still does. But I remember at the time of cash and counseling, the list of people that could not be hired in New York was unlike anywhere else in the country. It's changed. And what is it now?
Well, it's everyone except spouses.
Except the legally responsible.
Right, yeah.
But like in Florida, for instance, even in cash and counseling, you could hire a spouse or a parent of a child.
And it's still for the prevailing Medicaid wage? You know, if you were to hire a home care worker? I mean, that's...
So one of the aspects, this is one of the things we capture in our national inventory, but under the ideal cash and counseling model, the participant sets the wage. I mean, because put it this way, one way to look at the budget authority model is it's a capitated budget at the level of the participant. If this is, so if they use the money for one thing, they can't use it for something else. I mean, the person is literally thinking, what's important to me? Some states, the state sets the wage. An arcane point that may become, with some of these new regulations going through about the Department of Labor and their overtime issues like who sets the wage may work against the state. I mean, we'll see. We actually have a contract because part of the membership now of our center are all the financial management service, or many of the financial management service entities. We have a small contract to really investigate how much now is overtime an issue, how many people will be affected, how much, and there really are very arcane issues of does the state control the wage, does the state control the training, there will be very particular points that will guide who's going to be viewed for Department of Labor purposes as the employer.
Just trying to conceptualize this. I'm thinking that the participant gets a bucket of money, let's say, or budget. Out of that budget, they then are saying how many hours, based on their needs, they may need in direct care, home care. What does that bucket encompass besides that hands-on? What can they spend the monies on besides just the home care or the hands-on?
Right. And truthfully, that differs by state and by program. But I'll give you an example. I mean, because there's very specific issues. What is this budget replacing? What's the amount of the budget? And all of these I can talk about them, and then how can you use it? But I'll make it real. My son went on a budget in this last month. This was quite an experience for me, thinking you know everything about how it worked. But, so this is through the Department of Developmental Disabilities in Massachusetts. Now, I can tell you all of the experience where this goes back to your CDP program, how many years I knew the program existed and they refused to let me have it as an option, how many times they tried to talk me out of it. And then they had no materials that would describe the program. So then we got into setting the budget. The woman had no idea. So I said, by federal regulations, the budget, there's certain, it has to be an open, reasonable, there are certain federal regulations. She said, oh. So then we got into what can you spend money on? And so for my son's case, it's a general budget for employment-related services. But he can hire someone to help him find a job, you know, which includes a lot of things from application process, resume development, job development. But in his case, a subway pass. He needs a telephone. So the budget, he has a fixed budget. In his case, the budget is $15,000 a year, prorated by month. And he has the ability to go to really say, these are the things. But then, you know, then you have this experience. Okay, he wanted, we had bought him a laptop, and he wanted to be able to connect to the internet, and they said no. Now, there's a lot of things about how a state runs such a thing that need training. But the budget really could be very flexibly used if people allow that to happen. The United Kingdom, this one's sort of interesting because we've gone and done consultation there, and they very quickly adopted this into their social service delivery system, whole scale. But now they wanted to develop it into their national health system, and I was going, I mean, how will this work? But they really now have finished, and you can get these online, a whole series of experiments, and some of their greatest success are with people with serious mental illness. But one of the keys is that the budget has to be at least of a size to make it worth managing, and people have to have serious flexibility on how they use it. Were two of the markers of success in the United Kingdom. So.
Earlier in the presentation, you had shown a comparison between what users of this service were paying their home attendants,
yes,
and I guess the average rates that
yes.
people were making.
Yeah.
Was that the average rate that somebody gets, or the average rate that somebody pays an agency to get somebody? Because that includes fringe benefits, indirect, and whatnot. So what's the actual
remember,
cost?
these are early 2000 figures, but no, this is what the worker got.
Okay.
But I mean, I'll use an example. One that I happen to remember. It was like the state of Arkansas was paying agencies $12.50 an hour for personal care, but the worker was getting about $7. So there was a lot of wiggle room, you know, for savings on the administrative side. That was one area. We actually, Arkansas used a figure of around $8 as a heuristic device for creating the budget. But then the participant had freedom within that. Can you set your own wages? No,
the state sets the wages.
So, and they're negotiating.
Well, I'm sorry, no, that's not true. The state sets the rate, but the fiscal intermediary sets the wages. So the management, financial management group sets the wages. Now, of course, in connection with their contract with managed care plan. So it's changing. The interesting thing I wanted to ask you, in New York, is because you already know, I'm sure, and there is an exemption from the Nurse Practice Act, which makes this program really crucial for folks who are in nursing homes to come back and live out into the community. How does this apply, and how is it relevant in other states?
So this is, because your interests are so, rightly so, connected to New York. AARP's long-term care scorecard, this is one of the measures that they use of, I don't know what to call it, participant friendliness, but they have maybe 11 different aspects of the Nurse Practice Act and how are they handled in other states. Now, I'll say one thing that's sort of arcane, but then I'll come back to managed care. New York, I think the exemption is based on the fact that the people participant hires are like family. I think that's whereas in states like Texas, what they pioneered is more this nurse delegation, where long as the nurse has trained, you know, the person. I mean, I was amazed when my dad, required so many quasi-medical of what we got trained for wound care, et cetera. But you can see on the AARP report card how each state varies along that. One of the reasons that's important to managed care corporations, at least I've found, and I'll use this, is, like say I'm in Massachusetts, which has a very limited nurse practice exemption. Every time the person needed medication, they had to bring a nurse out. And if they did it under participant direction, they didn't have to do that. So all of a sudden there's numbers of financial incentives that once you understand the model better, you can see why people would care.
Except if you're seeking that in the medical model, which is still very difficult, so.
I guess that goes or lends itself to, with the model, I'm thinking carve-outs from what they can capture. Because I'm thinking from our organization, I know we have a plan of care for members who are enrolled in our program. When they're on the consumer-directed care program per se, they don't have an active plan of care whereby they are assigned a nurse. So when a nursing need comes in, we would have to get it either through our CHOP, services skilled services need, but it's not part of our LICSR or licensed agency. So I need to understand that dynamic more, whether or not there's particular carve-outs from this model when you're in a home care or managed long-term care setting. Right.
And I mean, being overly simplistic, which I know I won't get away with for long, there really are vagaries of how things work in different programs based on tradition. I mean, certainly in some states the participant develops a very detailed spending plan, and it's integrated with an overall plan of what the informal care providers are going to do. And more in the future, how that gets tied back to the acute, an overall plan as you integrate acute behavioral long-term supports. Yes?
Actually, it's funny that this is very relevant to my life right now, because it turns out that my grandma actually just had to go into the hospital, so she just had to, she's just working with a social worker now, which of course my parents are like, oh, did you hear the social worker did this and that, that's related to your career? I'm like, I don't really need to hear right now. But, so she, when she leaves, I guess that's I'm thinking of people in this very vulnerable state. So like, is that the social work, the case manager role, the training that you were talking about to get them to know about all these options of developing a plan? It seems like when they come out of a hospital, they're going to be overwhelmed anyway with like medical needs. And how does that communication work amongst the interdisciplinary team with more of the medical, like if they need to reach out to doctors or to nurses, and if they're in a home care setting, if they go back to their home?
Right. I mean, I'll answer that by going a little broader.
Yeah.
I mean, there's tremendous interest across the whole country in, what's going under the jargon of transitions. I mean, and rehospitalizations, and it is very hard to implement home care, period. I mean, which is sometimes the incentive for institutional placement, short-term or longer. So, you have a lot of these different models. Eric Coleman, this mirror neighbors on looking at transitions and that whole area. But in every single one of them, you'll find a very important part for person-centered or patient-centered care. And that's if the person doesn't buy into certain and understand certain aspects asbestos of the plan, what makes you think they're going to be compliant? You know, with what professionals should be doing. But I mean, I'll take an easier example, because it's easier when you're not in a crisis mode. But another type of transition, this whole money follows the person effort to help people get out of institutions, and which is often a matter of having the flexibility to pay the deposit or help with moving their furniture. This is a place that participant direction can shine. There's also time to pull it off, but the flexibility to pay for what's actually needed at the point in time it's needed is a better example of how it works easily.
Just to piggyback on that, I think access to the knowledge, because I would be curious how much would be known within a hospital setting as part of discharge planning, that this is an option as you go to a home care agency, that you can request this, or if you're long-term, this is something that you can request at any point in time.
Right.
I think people fail to know about it because they don't know it. It's just in general. It's just getting the information out there. Who are the holders of this information from setting to setting?
So this, I go back to my son, for example, in the developmental disabilities world. Massachusetts actually has a bill in final stages now that, at least in developmental disabilities, it would require this option to be offered at the time of every reassessment. It would spell out, what kind of information, in what format, training for agency people, some money for retraining and retooling for agencies. But it would be a much more systematic way of going.
That's happened in New York as well for the fire programs with a fully integrated, the dual programs, which are now, which you referred to earlier. And they're requiring that the managed care companies inform all enrollees that this is an option. And at each reassessment, which is every 180 days. So it is being done. But you're right about hospital staff, because it's, I would say, 60%, 50%, I'm being generous, know that the program even exists. And they pick up the phone for, whatever agency responds the quickest, and, naturally. And consumer directed is not,
Well, I'd so support that. We get a team of social workers that routinely get calls from hospital social work discharge staff that have no idea where to send their people with whatever, so here you go with training. I mean, and we've tried to do that. How do you get into hospital, into the discharge section, with the social work staff to do training, but they are all over the hospital. It's difficult to get them in one place for any more than, 5 minutes, and staff turnover, etc. So, and they are absolutely key players in this. Absolutely, yeah.
I meant to discuss this earlier, but I attended a meeting last week about care transitions, and Dr. Coleman, Eric Coleman, was the speaker for the day. And Mount Sinai's geriatric emergency department was sponsoring this. Mount Sinai has so many care coordination programs going on in the hospital. They now have a director of care coordination to coordinate their care coordination programs. So depending on what unit you end up in, you might get one type of care coordination. If you're in another unit, you get another type. And they've reached the point of saturation where they now have a director who's trying to coordinate all the care coordination. But the point in my discussion with him, this bridging the medical to the social model continues to be a problem, and he firmly acknowledges that in all of his work, with the transitions coach, that how you get the coaches to understand the intersection between the medical and the social, and how you transition that care in a more seamless way, continues to play many of these programs that are, as we see, everyone's implementing some kind of care transitions. But what you're speaking to, it really is an issue, and Kevin spoke briefly about the work that he's done with the veterans. That's another whole community, a population that, what's happening in the VA, people have no idea what services, programs are available. And linking the medical, non-VA medical with the medical VA, with the social services community, it's just not happening. And this just speaks to the problems we're facing, both from training as well as how do we now take something that has some efficacy, and how do we get the key people involved in understanding here's an alternate pathway. So what you're speaking to is certainly resonating in the field.
Actually, if I may, to that point, we do the Coleman model in Queens. And when you're saying about the silos of medical and social services, I mean, that's totally what it has been. But what I'm seeing, and I think it depends on the hospitals, because some of these hospital administrators totally get it. They're not making any money off of it, but they understand it's the right thing to do for the patient, to hook them up, to empower them to be able to make their own decisions at home. So it's almost like, one step at a time, one hospital at a time, so while we're working with 5 hospitals, we have 2 that get it, and the other 3, so a little bit at a time.
I'm sure we could go on and on. I'd like to go on and on, but
someday we must.
And we're going to, and we have lots of exciting plans, not only for the center, but for Dr. Mahoney. And hopefully we'll get to see a lot more of him as time goes on. I did want to take the opportunity, to thank everyone for coming today. Also, I was reminded by Dr. Gelman, long-distance communication, you agency providers will be receiving a survey shortly from the center that will be asking about what your training needs are. And some of the issues that are going on. I just happened to look at the first draft of the survey today. So you'll be hearing from us. This is our very first attempt to bring in an outside speaker and to, bring us all together. And just based on, given what's happening in this city over the last 10 days, I'm really impressed not only with the work Rebecca did to get all of you here, but the work all of you did to get here after receiving our multiple invitations. But I want to personally thank Dr. Mahoney for being here, and thank you for letting me get into the train station. Thank you all so much. I don't have any, Rebecca, I'm sure I'm forgetting something I shouldn't forget.
No, just if you didn't get a chance to sign in on your way in, just sign in on your way out.
Yes, please do.
Yeah, right up here on the table up here.
Thank you all so much. No, I know. Now I got you here already. We're not going to let go. No. Sorry.
It's all familiar things.
We've been playing email for about 5 minutes, but now we're connected. So we're going to go slow. I didn't mean to.
It's getting a little tense. It's getting a little tense. Like, that was really important. So
I would enjoy coming when it's